Hello and welcome to Dr. Ignacio's medical tutorials, and today we're going to be talking about mechanism of fever and the approach to pyrexia of unknown origin. Before learning about fever, we should know what is normal temperature. So it is the range from 36.5 to 37.5 degrees Celsius or 97.7 to 99.5 degrees Fahrenheit. This is the core temperature. Or the mean oral temperature is 36.8 plus minus 0.4 degrees centigrade. So what is fever then? Plus minus 0.7 degrees Fahrenheit. Due to the diurnal variation in temperature, the cutoff point for fever varies during the morning and in the evening. In the morning or 6 a.m. it is more than 37.2 degrees Celsius or 98.9 degrees Fahrenheit, while in the evening or 6 p.m. it is more than 37.7 degrees Celsius or 99.9 degrees Fahrenheit. So what are the sites to measure the temperature? The oral temperature in the mouth, the rectal temperature in the rectum, which is 0.4 degrees Celsius to 0.7 degrees Fahrenheit higher than the oral readings. The tympanic membrane thermometers is shown here, which can measure the radiant temperature in the unadjusted mode, or on the basis of normograms calculate the actual core temperature in the adjusted mode. The radiant temperature are 0.8 degrees Celsius lower than the rectal temperature. Axillary temperature, although widely used, are less accurate. This is the tympanic membrane thermometer, and this is the rectal thermometer. So fever versus hypothermia. Fever is an elevation in the body temperature that exceeds the normal daily variation, and fever occurs in conjunction with increase in the hypothalamic set point. The hypothalamic set point also increases. And hyperpyrexia, not to be confused with hypothermia, is actually a fever more than 41.5 degrees Celsius or 106.7 degrees Fahrenheit. Due to a natural thermal ceiling, due to infectious disease, temperature rarely exceeds 106 degrees Fahrenheit. So when there is a fever more than 106.7 degrees Fahrenheit, the causes are usually CNS hemorrhages. Hypothermia or heat stroke has been covered in another presentation, although it is characterized by an uncontrolled increase in body temperature that exceeds the body's ability to lose heat. The setting of the hypothalamic thermoregulatory center is unchanged. In contrast to fever in infections, hypothermia does not involve pyrogenic molecules. Exogenous heat exposure and endogenous heat production are two mechanisms by which hypothermia can result in dangerously high internal temperatures. Excessive heat production can easily cause hypothermia despite physiologic and behavioral control of body temperature. This is essentially heat stroke. So talking about the pathogenesis of fever, what are pyrogens? What are pyrogens? Pyrogens are any substance that cause fever. Pyro means fire. And exogenous pyrogens are pyrogens that are derived from outside the patient. So they can be microbial products, microbial toxin, or whole microorganism itself. Example of pyrogens are lipopolysaccharide or endotoxins, which is produced by the gram-negative bacteria, enterotoxins of Staphylococcus aureus, group A and B streptococcal toxin, toxic shock syndrome toxins of Staphylococcus aureus. Here we see the lipopolysaccharide or endotoxin of the gram-negative organisms. So what are endogenous pyrogens or pyrogenic cytokines? These are the cytokines that are small proteins which regulate immune, inflammatory, and hematopoietic processes. These are the pyrogenic cytokines or the cytokines which cause fever. Interleukin-1, interleukin-6, tumor necrotic factor, ciliary neurotropic factor, and interferon alpha. In the body, there is a natural thermostat which maintains normal temperature. Neurons in both preoptic anterior hypothalamus and the posterior hypothalamus receive the two kinds of signal. So the natural thermostat is in the hypothalamus, in the anterior preoptic and the posterior hypothalamus. They receive signals from nerve and blood. So one signal is obtained from the peripheral knobs that transmit information from warmth, cold receptors in the skin, and another signal is from the blood which bathes the region. These two types of signals are integrated by the thermoregulatory center of the hypothalamus to maintain the normal temperature. So here is the mechanism. If it is too hot and it affects the hypothalamus, then the person will at first undergo normal changes. He will take his clothing off, he will bathe, he will drink cold fluids, and accompanying with this are the physiological changes like vasodilation of the surface capillary. Sont vessels will constrict, there is increased sweating, decreased metabolic rate, hair lie flat, and the body loses heat and becomes cool. In contrast, when you are in Siberia or Mount Everest and the temperature is too cold and this cold temperature affects hypothalamus, at first your behavioral changes are involved, so you will wear warm caps and you wear coats, and later there will be physiological changes along with the behavioral changes, like there will be vasoconstriction of surface capillaries, the sont vessels will dilate, there will be decreased sweating, increased metabolic rate, hair will stand on end, and there will be shivering of the muscles, and the body will heat up and reach the normal temperature. So the pathogenesis of fever. So there are infection, microbial toxins, mediator of inflammation, and immune reactions. This will cause recruitment of inflammatory mediators like monocytes, macrophages, endothelial cells, and others, and they will trigger the synthesis of pyrogenic cytokines like IL-1, IL-6, TNF, and interferon, and via circulation they will reach the blood bathing area of the hypothalamic endothelium, and microbial toxins will also reach this hypothalamic endothelium and induce prostaglandin E2. And in the brain, the prostaglandin E2 will cause the synthesis of cyclic AMP or CAMP, and this will elevate the thermoregulatory point, and the body will conserve heat, the person will shiver, there will be increased heat production, which becomes present as fever. So this is the chart. So what is pyrexia of unknown origin, or fever of unknown origin? This was originally defined by Peter Sudhoff and Beeson in 1961 as an illness of more than 3 weeks duration with fever of more than 48.3 degrees Celsius or 101 degrees Fahrenheit on 2 occasions, and an uncertain diagnosis despite 1 week of inpatient evaluation. Pyrexia of unknown origin is now defined as fever more than 38.3 degrees Celsius or 101 degrees Fahrenheit on at least 2 occasions, illness duration more than 2 weeks, no known immunocompromised state, and diagnosis that remains uncertain after a thorough history-taking, physical examination, and the following obligatory investigation. The physical examination should also be very thorough, including every skin surface and every mucous surface, and the history-taking also should be very thorough. The essential investigations are ESR, CRP, platelet count, total leukocyte count, differential leukocyte count, hemoglobin, electrolytes, and creatinine. Other investigations are total protein, ALP, ALT, AST, LDH, creatine kinase, ferritin, ANA, rheumatoid factor. These are for the autoinflammatory diseases like SLE and rheumatoid arthritis. Protein electrophoresis, urine analysis for UTI, blood cultures, urine culture, chest X-ray, abdominal ultrasonography, tuberculin skin test for tuberculosis, and nowadays PCR for COVID-19. Other investigations in the tropical area are thick smear and thin smear for malaria, Widal test for typhoid, hepatitis A, IgM and IgG, HBs, AZ, and stool microscopy. So what are the causes of PUO? The causes of pyrexia of unknown origin are limitless, but in short form, they are mainly enteric fever, malaria, UTI, tuberculosis, chronic hepatitis, HIV, occult abscesses, example liver abscess, pelvic abscess, mastocytitis, sinusitis, osteomyelitis, meningitis, infectious mononucleosis, infective endocarditis, brucellosis, CMV, toxoplasmosis, chalazia, and COVID-19. Autoimmune diseases like rheumatoid arthritis, ankylosing spondylitis, adult onset juvenile rheumatoid arthritis, Kawasaki disease, SLE, inflammatory bowel disease like Crohn's disease and ulcerative colitis, PAN, Takayasu arthritis, pseudogout, Felty syndrome, familiar Mediterranean fever, gout, sarcoidosis, and Sjogren's syndrome. Among the malignant causes are leukemia, lymphoma, Langerhans cells, histiocytosis, amyloidosis, most solid tumors and metastases like breast, colon, hepatocellular carcinoma, lung CA, pancreatic CA, and angiomyelitis. So let's go to this chart which demonstrates how to approach pyrexia of unknown origin. This is the definition of pyrexia of unknown origin. Fever more than 38.3 degrees Celsius or 101 degrees Fahrenheit, and illness lasting more than 3 weeks and no known immunocompromised state. We first take history and physical examination. We'll stop the antibiotic treatment and glucocorticoids if they are being used. We'll conduct the battery of all obligatory investigations we talked about earlier. We'll exclude manipulation with thermometer to exclude factitious fever or other psychiatric conditions like Munchausen syndrome. We'll stop or replace medication to exclude drug fever, which means the anticholinergic drugs, which can also cause fever. And then we'll see for potentially diagnostic clues. We're going to be talking about potentially diagnostic clues. And then if the potentially diagnostic clues which come from doing physical examination are present, then we'll do guided diagnostic test, and it can yield diagnosis or it may not. So if the PDCs are absent or misleading, we'll do cryoglobulin and fundoscopy, and then we'll do FDG plate, which means fluorodeoxyglucose positron emission tomography or CT scan. And if in this the scintigraphy is normal, then we'll do repeat history and physical examination. We'll also perform PDC driven invasive testing. If the scintigraphy is abnormal, we'll do confirmation of the abnormality by biopsy or culture. And if it is a diagnosis, then we'll have a diagnosis. But if it does not yield the diagnosis, then we'll go here and do repeat history and physical examination and perform PDC driven testing. If this is diagnosis, then we have our diagnosis. If it does not yield diagnosis, we'll do chest and abdominal CT scan. We'll also do temporal artery biopsy for people more than 55 years to rule out Takayasu arteritis. If it still does not yield a diagnosis, then we'll if the person is stable, then we'll follow up for new potentially diagnostic clues or use NSAIDs. If there is deterioration, we'll do further diagnostic tests and consider therapeutic trial. I'll explain the components of this chart in more detail later. So here we are. What are the potentially diagnostic clues? For potentially diagnostic clues are obtained through complete and repeated history taking and physical examination, and they are actually the localizing signs, symptoms, and abnormalities that will potentially lead towards a diagnosis. So after doing repeated physical examination, you may find a hepatomegaly or splenomegaly. So these are the PDCs. Although PDCs are often misleading, only with their help can a concise list of probable diagnosis should be made. Complete physical examination should be done every day in the case of PUO to seek out PDCs. The scintigraphy is actually a scan, and it will, if there are places of high inflammation, then the scintigraphy will be more prominent in that area. So what are the empirical therapy for pyrexia of unknown origin? Antibiotics and anti-tuberculous therapy. Antibiotics or anti-tuberculous therapy will diminish the ability to culture the bacteria or mycobacteria. However, if there is hemodynamic instability or neutropenia, then empirical antibiotic therapy can be started. If the tuberculin skin test is positive, or if granulomatous diseases are present with energy and sarcoidosis seems unlikely, or in areas with high prevalence of tuberculosis, especially in the tropics, then treatment for tuberculosis should be started. This is because in miliary tuberculosis, to obtain a diagnosis, this is very difficult. And if the fever does not respond with 6 weeks of empirical anti-tuberculous therapy, then another diagnosis should be sought. Another one is colchicine, if familiar Mediterranean fever is suspected, and NSAIDs and glucocorticoids. The ability of NSAIDs and glucocorticoids to mask the fever while permitting the spread of infection or lymphoma dictates that their use should be avoided on this infectious disease, and malignant lymphoma have been largely ruled out. An inflammatory disease is probable and is likely to be debilitating or threatening. So NSAIDs and glucocorticoids should be only used after you rule out infectious disease and malignancy. Empirical therapy for pyrexia of unknown origin by anakinra. So therapeutic trial with anakinra, which is an interleukin-1 receptor antagonist, can be considered in patients with fever with unknown origin has not been diagnosed even after late-stage diagnostic tests. So it is similar in efficacy to glucocorticoids but has less metabolic, immunologic, and gastrointestinal side effects. Thank you. The reference has been Harrison's Textbook of Medicine, 20th edition, and OP Guy's Textbook of Pediatrics, 9th edition. Please subscribe to this channel. This has been Dr. Ignatius Cole.